Welcome and thank you for joining us for this webinar on vaccines and solid organ transplant, answering the who, what, when, and how on vaccinations. This webinar is co-sponsored by the following three COPs: Advanced Practice Providers, Infectious Disease, and Transplant Pharmacy. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership poll question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded and the archive will be available on all three COP hubs by next week. Please note that your lines have all been muted so that only the presenters can be heard for the archived recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A section in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the COP hubs following the webinar. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn this session over to our moderator, Jennifer Burns, to begin our presentation.
Thank you. Welcome everyone to the next AST webinar about vaccines and solid organ transplant. It is my pleasure to be moderating the session today. And my name is Jennifer Burns, and I'm an outpatient abdominal transplant pharmacist at Duke University Hospital. Today, we have four amazing presenters who will be sharing their expertise regarding vaccination and solid organ transplant. Our first speaker is Dr. Amy Feldman, who is the Medical Director of Liver Transplant Center at and the Fellowship Director of the Advanced Hepatology and Liver Transplant Fellowship at Children's Hospital, Colorado. Her research interests focus on immunizations and vaccine preventable infections in the solid organ transplant population. And she is currently funded by a K08 award from the Agency for Research, Healthcare, and Quality. Our second speaker is Arin Jantz. Arin is a board certified solid organ transplant clinical pharmacist at Henry Ford Health in Detroit, Michigan. She practices in the areas of both abdominal and cardiothoracic transplant. Our third speaker is Kristen Neuhaus. Kristen is a solid organ transplant clinical pharmacist at Cleveland Clinic in Cleveland, Ohio. Her practice is primarily inpatient with the lung transplant patient population. Our fourth speaker is Kristen Ryland. Kristen is an associate professor of medicine at Mayo Clinic in Jacksonville, Florida, and has worked in hepatology and liver transplant since 2010. She is the lead advanced practice provider in transplant and is the program director of the Solid Organ Transplant APP Fellowship Program. We also have Dr. Olivia Cates joining us for our Q&A portion of the webinar today. Dr. Cates is a transplant and oncology infectious disease specialist at Johns Hopkins University in Baltimore, Maryland. Here are our conflicts of interest and grant disclosures as listed below for our speakers. And with that, I will turn it over to Dr. Feldman, who will be our first presenter of the day.
Thank you so much, and thank you all for joining us today. We have four main goals or objectives of this webinar. First is to describe the burden of illness from vaccine preventable infections in the solid organ transplant population. Second, we will review current vaccine policies in both the pre and post-transplant periods. Third, we will discuss barriers to immunization of the transplant population. And finally, we will share best practice immunization transplant experiences. And just a small disclaimer, in today's webinar, we will not be including information about COVID and COVID vaccine. So why are transplant recipients at increased risk for infection and specifically vaccine preventable infections? Well, the main reason is that our patients are on immunosuppressive agents. And these agents decrease the body's ability to fight infections. Certain transplant recipients may also experience post-transplant hypogammaglobulinemia. They may have a risk of acquiring hepatitis B or hepatitis C from their donor organ, or they may have underlying conditions that include asplenia or impairment in splenic function that predispose them to getting infection with encapsulated organisms. Finally, in the pediatric population, some children are transplanted so early in childhood that they may not have had time to complete a full set of childhood immunizations. So for all of these reasons, our patients are at risk for infections. But are our patients at risk for vaccine-preventable infections? In order to answer this question, my team used the Pediatric Health Information System Database, or PHIS database, that collects data from over 40 freestanding pediatric institutions. So we looked at 7,000 pediatric transplant recipients and found that 16% of them, or 1 in 6, was hospitalized in the first 5 years after transplant with a vaccine-preventable infection. And this number doesn't even include those patients who had a vaccine-preventable infection that was cared for in the outpatient world. These vaccine-preventable infections were associated with significant morbidity and mortality. They increased the length of transplant hospitalization by 20 days, and they increased the cost of transplant cost by $120,000. And the most common vaccine-preventable infections that we observed were influenza, rotavirus, varicella, pneumococcus, and RSV. Likewise, Kumar et al. Studied the impact of the H1N1 pandemic on the transplant population. So they looked at 237 laboratory-confirmed cases of H1N1 in transplant recipients and found that 71% of them required admission to the hospital, 16% required admission to the ICU, 9% required mechanical ventilation, and there was a 4% mortality rate. Likewise, Olarte and Kumar compared the rates of invasive pneumococcal disease in both the adult and pediatric solid organ transplant population compared to the overall healthy population. And you can see that the rates of pneumococcus were 13 times greater in both the adult and pediatric transplant populations than the healthy population. Finally, Madeline et al. Evaluated for HPV-induced cancers in 187,000 solid organ transplant recipients. And they found that for transplant recipients, there was a 3 to 20-fold increased rate of in situ cervical, vaginal, anal, penile, and vulvar cancer. Likewise, there was a 2 to 7-fold increased rate of invasive GU cancers. So yes, vaccine-preventable infections are a significant problem in the solid organ transplant population that not only occur frequently, but also are a significant cause of morbidity and mortality. So what can we as a transplant community do to help prevent these vaccine-preventable infections in our population? The first thing is to get in as many immunizations as possible before transplant. So we know that vaccines are more immunogenic before transplant, before a patient is started on immunosuppressive agents. We also know that response to vaccine often decreases as patients get sicker and sicker. For example, only 28% of cirrhotics developed protective antibodies against hepatitis B, compared to 97% of healthy controls. And likewise, only 37% of patients with decompensated liver disease developed Hep A antibodies, compared to 71% of those with compensated disease. So it's really crucial that we start thinking about and talking about immunizations as early as possible, even before we get to the transplant evaluation. It's also important to understand that pre-transplant immunizations improve response to immunizations after transplant. So even though there is certainly some waning of immunity after transplant when patients go on immunosuppressive agents, immunization pre-transplant generates an immune memory which can be successfully boosted after transplant. And if you look at the figure on the right, you can see that for diphtheria, Hib, hepatitis B, pneumococcus, and measles, the higher your pre-liver transplant titers are on the y-axis, the higher your post-transplant titers are on the x-axis. And finally, it's really important that we make use of the CDC's minimum age, minimum interval schedules in order to accelerate vaccines when possible. So the measles, mumps, rubella, or MMR vaccine, and the varicella vaccine can be accelerated to 6 months of age, and the HPV vaccine can be given as early as 9 years of age. Here is a chart showing pre-transplant and post-transplant vaccine recommendations for both the pediatric and adult transplant population. Let's take a moment now to dive into some of the individual vaccine recommendations. So let's start with live vaccines, MMR and varicella. In healthy children, we wait until 1 year of age to give these vaccines. But in the transplant population, they can be given as early as 6 months of age. Currently, it is recommended that we wait 4 weeks between administering live vaccines and proceeding with transplant. However, my fellow Dr. Kemi and I are studying whether this 4-week waiting period is really necessary. A second dose of vaccine can be given 4 weeks after the first dose if there are 4 weeks anticipated before transplant. And if a child receives the live vaccines before 1 year of age and has not been transplanted by 1 year of age, then they should go ahead and get another set. Likewise, the HPV vaccine can also be accelerated and can be given as early as 9 years of age. And in the transplant population, we recommend 3 doses of HPV. For the hepatitis B vaccines, a 3 to 4 dose series should be given, and then titers should be checked. If the anti-hepatitis titer is less than 10, one should consider revaccination. And for those patients with end-stage renal disease who are on dialysis, higher dose of hepatitis B vaccine can be used. For the meningococcal vaccine, the quadrivalent vaccine against A, C, Y, and W are recommended for 11 to 18-year-olds and younger children or older adults who are at high risk. Likewise, the Men-B vaccine is recommended for those patients with functional asplenia, complement deficiency, eculizumab use, and other special populations. In the adult population, herpes zoster virus should be given to candidates who are 50 years and above. And the recombinant zoster virus is recommended over the live attenuated zoster virus. Pneumococcal vaccine recommendations have changed recently, so let's take a second to look at those updated recommendations. So for children ages 2 to 18 years, it is recommended to receive both the PCV13 and the PPSV23. If a child is vaccine negative, you would give the PCV13 followed by the PPSV23 vaccine 8 weeks later. For children ages 2 to 5, 2 doses of PCV13 would be given. And for children ages 6 and above, 1 dose of PCV13 would be given. For adults 19 and above who have chronic heart, liver, and kidney disease, if they are PCV naive, then they should either receive 1 dose of PCV15 followed by a dose of PPSV23 or 1 dose of the PCV20 vaccine. How about post-transplant? Let's start with the inactive vaccines. So most centers recommend restarting inactivated vaccines 3 to 6 months post-transplant. For influenza, the Infectious Disease Society of America and Medicare recommend that the flu vaccine should be given before discharge during flu season. The KDIGO organization recommends the flu shot is given 1 month post-transplant. And in a study by Perez Romero et al. Of almost 800 transplant recipients, they found that the response and safety profile was similar in those who received the flu shot less than 6 months post-transplant and greater than 6 months post-transplant. Live vaccines are a little bit more controversial after transplant. So historically, live vaccines were not recommended after transplant due to concern that you could incite vaccine strain sepsis in an immunocompromised host. However, community acquisition of measles is now a very real risk. And so in 2019, a group of international experts got together to review all of the literature. And their final recommendations was that you should consider live vaccines for liver and kidney transplant recipients who were clinically well, had not received recent biologics, and met 3 criteria. First criteria being that they were a minimum of 1 year out from transplant and a minimum of 2 months out from any acute cellular rejection. Second criteria that they were on low dose immunosuppression as defined by steroids less than 2 mg per kg per day or less than 20 mg per day, tacrolimus trough less than 8 times 2, or cyclosporin trough less than 100 times 2. And finally, that the patient had a normal immune system as demonstrated by age-appropriate ALC, CD4, and IgG counts. So are we as a community doing a good job immunizing transplant candidates and recipients? In 2019, my team attempted to study this question. So what we did was collected the immunization records on the day of transplant for every child across America who underwent liver transplant, not for acute liver failure, for a 1 year period. And then we classified the children as either being up to date or not up to date on immunizations. And we used 3 different schedules. First, the National Immunization Survey, just requiring 7 minimum vaccines. Second, the standard CDC schedule. And finally, the accelerated schedule, allowing for MMR and VZV to be given at 6 months and HPV to be given at 9 years. So you can see that using the minimum criteria, only 55% of transplant recipients were up to date for age on immunizations. Using the standard CDC criteria, only 29% were up to date. And using the accelerated schedule, which is what we should be using for all of our patients, only 19% of pediatric liver transplant recipients were up to date for age on immunizations. And there was no demographic or clinical features that were specifically associated with under-immunization. Interestingly, I thought that it would just be that children were missing a dose here or a dose there, but of those children who were not up to date, over half of them were missing 4 or more immunizations. In this study, we also found that of children ages 6 to 11 months at transplant who were eligible for live vaccines, only 25% of them had received an MMR dose and only 15% had received a varicella vaccine. Compared to the overall population, liver transplant recipients had lower vaccine rates for every single one of the 7 individual vaccines. And only 52% of liver transplant recipients who were older than 6 months at the time of transplant had received their seasonal flu vaccine. The same is found in the adult population. Only 62% of adult lung transplant recipients received a pneumococcal vaccine. Only 52% of adult solid organ transplant recipients received a flu vaccine. And less than 10% of pediatric renal transplant recipients received a PPSV23. So no, unfortunately, we are not doing a good job immunizing our transplant patients. So why is that? Why is it that these high-risk patients are less immunized than their healthy counterparts? What are the barriers to immunization of the transplant population? In order to study this, my team performed semi-structured qualitative interviews of 80 pediatric transplant stakeholders. So this included parents of transplant recipients, primary care doctors who had taken care of a transplant patient, cardiologists, hepatologists, nephrologists, transplant infectious disease doctors, and transplant nurse coordinators. And we identified 4 barriers that existed across all organ types and across multiple centers. So first, there are gaps in knowledge about safety, efficacy, and timing of vaccines in the pre-transplant period. Second, there is a lack of communication, coordination, and follow-up amongst a big multidisciplinary transplant team. Third, there is a lack of a centralized immunization record in this country, and it can often be hard for subspecialists to even access a child's records. And finally, often before transplant, the subspecialty clinic, whether that be hepatology, cardiology, nephrology, serves as the medical home, but may be unable to provide vaccines. So my team has created one solution that leverages mobile devices. So we created a immunization mobile health app, and it does several things. First, it provides education about vaccine safety, efficacy, and timing in the pre-transplant period. It houses a centralized immunization record for each child that's easy to access. It has a chat feature so that parents and pediatricians and transplant subspecialists can all communicate even if they're not on the same EMR. And finally, it has computer-generated alerts using the CDC accelerated schedule that sends a notification to the parent, the pediatrician, and the transplant team when a vaccine is overdue. So in summary, vaccine-preventable infections cause significant morbidity and mortality in transplant recipients. Immunizations are absolutely a critical part of the care of the transplant population. Vaccination status should be thought about early and reviewed as part of the transplant evaluation. And our goal as transplant providers should be that all of our transplant recipients are up to date for age at the time of transplant and then remain up to date in the post-transplant period. Thank you. I now would like to introduce my colleague who's going to give the Henry Ford Health experience.
Similar to what we've heard so far, updated vaccinations are strongly recommended at the time of listing for our abdominal and thoracic organ groups at Henry Ford Health. Typically, we follow the Advisory Committee on Immunization Practices, or ACIP schedule, but also taking into account some of the slides that Dr. Feldman presented earlier, that when patients are immunocompromised. Also, very similarly, suboptimal vaccination rates have been seen pre-transplantation in our population, and once again, often dependent on primary care physicians to administer patients' recommended vaccinations. Due to these low vaccination rates, and especially those being seen by our liver transplant team, in order to address it, there was a suggestion for the creation of a pharmacist-run vaccine clinic. We did develop a process that focused on the pre-liver transplant patient population with a pilot that started in 2018. Now, this really could have benefited any of our patient populations at Henry Ford Health, but we did have some additional reasons for our pre-liver transplant focus. All of our patients had their serologies for hepatitis A and B already drawn during workup that we could use to evaluate. And then we expected to see a significant benefit, as we do have a very robust liver transplant outreach program where we transplant patients far outside the Detroit area. Each adult patient being worked up for liver transplant was reviewed, and of note, our center is an adult-only center. We utilize vaccination history, including patient report, as well as electronic medical record. And we also utilize the Michigan Care Improvement Registry, or MICR, which is Michigan's vaccine repository system. We also did review the serology of all results that were available. And in order not to take on too much at one time, we plan to have a very targeted approach with the vaccines that were offered in our clinic. Those included hepatitis A, hepatitis B, and then both types of pneumococcal vaccinations that were available at that time. So PPSV23 or Pneumovax and PCV13 or Prevnar. Of note, we do at Henry Ford have the Heplisav B formulation for our hepatitis B vaccine, which is a 2-dose series. Each patient was reviewed using a specific process, with step one patient being reviewed and also identified through their schedule of upcoming in-person family meetings, which was done quite early in their transplant workup. Patients were then called over the phone, including the caregiver as well, to let patients know which vaccines were needed and also to give them education about the benefits of these vaccines. If patients were agreeable to it, we did verify vaccine coverage, including using information online or by phone. And additionally, because we are a specialty clinic, some of our billing practices had to be very specific. So we did use a web-based billing system called our Transact RX in order to bill for our Medicare Part D patients. Orders were placed, and then finally the vaccine appointment was scheduled for our patients. When patients were there for their appointment, vaccinations were administered by either the medical system or the pharmacist, and that was documented in the EMR. And for multi-dose series, patients were called by the pharmacist around the time when the next dose was due. They had the choice to receive the vaccine in an outside facility if that was more convenient for them, or they could also receive it at Henry Ford, where we attempted to schedule it with any of their upcoming in-person appointments. Patients were also really brought into the process as well and given a printout with due dates for their upcoming doses and a phone number of how to schedule. And as you can see, the form that we actually gave the patients. After this clinic was implemented, we did review the data, and we reviewed approximately 150 patients over the first year. And we did collect the data to compare our patients pre-implementation to post-implementation. And in the figures below, there were 127 patients in each group. And of note, this data was presented at the American Transplant Congress last year. Looking at the figure on the bottom to the left, the percentage of patients that had a vaccine series initiated that needed their vaccine prior to transplant was 15.6 in the pre-implementation group and had increased to 54.9% in the post-implementation group. Also of note, right next to that on the right, patients were considered up to date at the end of follow-up. That percentage increased as well from 9 pre-implementation to 31.4% post. And in the figure to the right, each of the vaccines were looked at separately. And for all 4 of the vaccines, the percentage did increase from pre to post implementation, though it was only statistically significant for the hepatitis B and PCV13 vaccination. Now, we had a lot of things that really helped us be successful. First, we had a strong multidisciplinary approach where the providers, coordinators, and medical assistants all worked very closely with us and were all very supportive. And we also had a collaborative practice agreement that that allowed us to review each of these patients independently. We also had an established workflow and tried to utilize the EMR to its fullest. The use of serologies and our MICR system was very, very helpful. We also always attempted to keep our focus on the patient. And so education and communication to both the patients and the caregivers were very important, especially for our end-stage liver disease patients who may have hepatic encephalopathy or may be very forgetful. It really helped to engage the support system to increase our percentage of involvement. Convenience was also really beneficial and helpful. And one of those things that we did to make it more convenient was for the patient was to finalize our billing process prior to rollout, as we didn't want any of our patients to be receiving a bill that was unexpected. Looking at our vaccination rates, they did increase, but there remains room for improvement. And there were a number of situations that resulted in potentially lower vaccination rates than what we expected. And those are areas that we thought could be opportunities for focus in the future. So for example, our patients admitted to the hospital during the workup that were maybe considered too ill to receive vaccines at that time, or who were actively infected, often had lower vaccination rates. Also, patients who were longer distance from hospital or where it wasn't very convenient, especially with their follow-up vaccinations. And then those who were deemed not to be transplant candidates, or those who needed to complete our series post-transplant, like Dr. Feldman mentioned, deciding on that specific time period was something that wasn't built in our process from the beginning. Finally, our hepatitis B formulation that we carry and prefer, HEPLISAV-B, was not covered by the majority of the Medicare Part D plans. So the patients that wanted to receive this, in order to make sure it was covered, we often had to refer them to outside centers. Lastly, we had some very unique situations come up during the COVID time period. It really limited feasibility because the family meeting was changed to a telemedicine visit during the pandemic. And a lot of patients were uncomfortable with any additional in-person medical care, not to mention a number of our centers who were already overloaded with other types of patients. This resulted also in, due to a significant change in the medical assistant team, they were really helpful in making sure the clinic ran smoothly, especially when we had multiple patients at one time. And due to these reasons, our pilot was put on hold during the pandemic, though there are some discussions to potentially restart it since it was beneficial to our patients, though it might be in a somewhat modified format. And we will now have Kristen talk about her experience at Cleveland Clinic.
Thank you. Here at Cleveland Clinic, prior evaluations have been completed describing pre-transplant vaccination rates in both the liver and kidney transplant patient populations. These results have highlighted several important factors, one being the demonstrated value of infectious diseases consultation in the early transplant evaluation phase. 2, identifying some of the barriers surrounding receiving vaccinations in the pre-transplant phase. And overall, it was found that opportunities do remain to optimize as well as standardize our current process of administering vaccinations prior to transplant, which then led to the evaluation in our heart and lung transplant candidate populations. Focusing now on the thoracic population, we evaluated 349 heart and lung transplant candidates at Cleveland Clinic over about a 2-year period. We assessed both serologic response as well as vaccination status for hepatitis A, hepatitis B, tetanus, pneumococcal, influenza, and additional organisms. Rates were compared for patients with an infectious diseases consult versus those without. And lastly, a goal was to identify what we considered missed opportunity doses, which were defined as the number of vaccine doses a patient was eligible for or recommended to receive, but did not during the allotted time frame before transplant. Data was reviewed for 91 heart transplant candidates. As you can see by the graphic on the left, there were numerically higher rates of vaccination series completion for hepatitis A, hepatitis B, pneumococcal, and zoster. As mentioned previously, ideally patients would be seen by infectious disease as early in the evaluation process as possible to allow for optimal timing and completion of vaccine series. We found that 62% of heart transplant candidates did complete their ID consult prior to the listing process. There were 258 lung transplant candidates that were reviewed. In the lung transplant group, patients with an ID consult demonstrated higher rates of hepatitis A, hepatitis B, and measles vaccination compared to those without, and also had numerically higher rates of vaccination series completed for pneumococcal. Similar to the heart population, 67% of candidates completed the ID consult prior to transplant listing. However, we did see that the lung transplant patients, once they were listed, had a much shorter wait time to transplantation with a median of about 70 days compared to hearts that had a median of 267 days. In total, for both heart and lung, it was identified that there were over 700 missed opportunity doses, which was approximately 1.5 vaccine doses per patient in the ID consult group and 2.5 vaccine doses per patient without ID. It was identified that the opportunity doses that we identified were most common for patients that had partial completion of vaccine series for hepatitis or pneumococcal vaccines. Some of the takeaways we found, we know that administration of vaccines and assessment of serologic response should be prioritized in the pre-transplant period. The results from the evaluation of heart and lung transplant candidates did demonstrate the positive impact of infectious disease consult and are consistent with the previous studies published at our institution in the other organ groups. There does remain a need to identify better methods to improve vaccination rates, particularly vaccine series completion for multi-dose vaccines. ID consult should occur early in the transplant evaluation period, taking into account that vaccine series may take weeks to months to complete. Another method to address the missed opportunity doses, including those with the ID consult, is incorporating additional resources such as transplant pharmacist team members, as well as creating tools to increase pre-transplant vaccination rates. Our institution currently uses standing orders for common pre-transplant vaccinations, such as influenza, as well as pneumococcal series, and also tools within the electronic health record, which include order sets, as well as reminder alerts to improve vaccination rates by notifying providers, nurses, transplant coordinators, as well as pharmacists, and even the patient if a vaccine dose is overdue. These tools were implemented following the results of the present heart and lung study that were just reviewed. So before highlighting what some of these tools in the health record look like, I just wanted to take a moment to describe the current work process for administering vaccines with our current workflow. So I'll use the lung transplant workflow as an example. First, the transplant evaluation process begins. Following this is the patient's first appointment with the transplant team. Here at the first appointment is where routine lab work is collected, which includes transplant and immunization serologies. As patients then proceed through the evaluation process, it is the responsibility of our wonderful transplant coordinators to maintain documentation of vaccination status. Following the appointment with the transplant team, a referral is typically placed to our infectious disease colleagues, where additional vaccines may be administered and other recommendations are made. For our lung transplant group, all patients must see ID for clearance as part of the transplant evaluation. However, patients can be listed prior to actually seeing ID. And lastly, coordinators follow ID recommendations and follow up administration of vaccines as they see patients in clinic. So we're currently in the process of implementing a tool in the medical record to identify patients that are appropriate for pre-transplant vaccinations. And this goes across all organs, again, to better standardize our current practice. So once the pre-transplant evaluation has begun, you can see the diagnosis code is selected in the box on the right or on the left. The electronic medical record is able to then identify patients through either a problem list diagnosis or an encounter diagnosis. From there, once the encounter is fully set up, the provider is able to navigate to a smart set category where if they type in vaccines, they'll have the option to select either serologies and vaccinations or vaccinations alone. And we're encouraging our team members to use the serologies and vaccinations order just to ensure that patients have their baseline serologies in place in preparation for the appointment with infectious disease. So the example on the left here demonstrates the selection for serologies, which defaults to being pre-selected, and the provider does have the option to deselect it if information is already available. And then to the right, you can see where the provider is able to select vaccinations. So while the order set is extremely helpful in ensuring patients have transplant serologies and vaccines ordered at the initial visit, a new functionality was implemented, which is referred to as the health maintenance tool, which displays several immunization alerts for organ transplant candidates. So this helps address one of the main barriers we've identified, which is the follow-up of vaccines that require multiple doses or are in a series. But mainly the goal of this is to really facilitate a team approach for completing vaccinations prior to organ transplant. So this tool populates on the sidebar of the patient's chart, so it's easily accessible for providers, and it provides a quick way to order necessary immunizations. For the future, we plan to evaluate how these new tools and order sets are being utilized. We'll continue to strive for optimal timing of vaccinations in the early evaluation phase, prior to listing if possible. And then lastly, continue to work to standardize the pre-transplant immunization process among all of the organ groups. And next, I'd like to introduce Kristen Ryland to go over the Mayo Clinic experience. Thank you.
Good afternoon. At Mayo Clinic, we also follow the ACIP guidelines, and we typically consider our patients with end organ failure in the immunocompromised category. So we do immunize people accordingly, even if they are outside of some of the traditional age range guidelines as set forth by the ACIP. For example, if a 35-year-old patient comes to us that has been exposed to chickenpox, we would recommend they do receive the Shingrix vaccination series pre or post-transplant, even if they are less than 50. So the previous panelists have done a great job describing the vaccine practices at their facilities and also across solid organ transplants. And I would like to focus on the kidney transplant recipient. Here is our pre-transplant vaccine workflow at Mayo Clinic. At the initial evaluation visit for a kidney transplant recipient, we do have each candidate seen by our infectious disease team, either in person or via video visit. We do have them complete the usual serologies, and hopefully they're available, the results are available at that visit. However, the team does go over a thorough history with each patient and may request additional serologies such as strongyloides or even schistosoma, depending on their travel history. So once the infectious disease team receives all of the results, they will review this and make recommendations, typically to the kidney transplant coordinator for vaccines. And we do provide a paper that has our recommended vaccines, but in addition, we offer the patient a chance to have their vaccinations while they are doing their evaluation at Mayo Clinic, or we do give them a prescription that they can take back home and complete at any pharmacy, health department, or with the local primary care providers. If they choose to receive their vaccines at Mayo Clinic, they do go to the allergy immunology clinic at Mayo where we handle those. Then subsequently, at each annual evaluation, our kidney patients are seen once yearly while they're on the wait list, and the wait time is approximately 5 years at Mayo Clinic in Florida for a kidney deceased donor kidney transplant. We do redraw some of these serologies, including viral hepatitis panel, HIV annually, and we may recommend booster vaccines, or we will give them a prescription to complete these at home. Why is it important that we review these serologies and redraw them in certain populations of patients? It's because many of these patients with end organ damage, including patients on hemodialysis or end-stage renal disease, do not mount a good vaccine response. So just because we're giving these vaccines does not necessarily mean that they're working as intended. So we do redraw titers at each annual visit when we see these kidney patients while they're on the wait list, and we may recommend that they repeat these vaccination series, including hepatitis B. So titers after vaccinations are not commonly used, but they are necessary for patients on hemodialysis or post-transplant patients, and titer of greater than 100 we were very comfortable with. However, in more recent times, any titer that is positive is acceptable, as we know that boosting that will only increase that titer level. At Mayo Clinic, we're similar to Cleveland Clinic. I think we use the same medical record system, but when I'm looking at serologies, I look under this nice infectious disease tab to the left. I can click each one of these, such as viruses, and it will populate to the right, and it shows you what the patient has had done when and what their titer results are. If you click on these, such as the CMV, IgG, and double click it and open it up, it will actually give you the levels. We document in the medical record. This is an example at the bottom of one of our progress notes. So we also include the levels of what's been done and when of their titers, and then we can also include an immunization history in our notes. So we do this. We ask our patients beforehand to bring their vaccine records if they're coming to us from elsewhere. And we also ask them to call us when they do receive vaccines, that we may enter it into their chart. We also use a health maintenance tab, and it's very nice in that it pulls in a lot of commercial pharmacies, CVS, Walgreens. So that is an automatic process that flows into our medical record. We can also enter manually outside vaccine results in this tab, and they will stay there. This is our recommended schedule for pre-transplant for solid organ transplant candidates. We will incorporate the new pneumococcal vaccines that were FDA approved in November of 2021. In addition, there's a new hepatitis B vaccine that came out that is the only 3 antigen hepatitis vaccine approved, and that was incorporated into ACIP guidelines in February of 2022. So we will incorporate these. We do use the current hepatitis B Heplisab vaccine, which is 2 doses 1 month apart, which I think is it's a little bit more immunogenistic for some patients and also less cumbersome in that they don't have to get three to possibly 4 vaccines. Post-transplant, this is our recommendations. We typically start vaccinations about 6 months after transplant. However, there are some exceptions. One is the influenza vaccine. If our patients are transplanted, say around August, we would recommend that they receive influenza vaccination at that time. And then we would also recommend a booster approximately 2 to 3 months later to help to carry them through the entirety of the influenza season. In our infectious disease notes pre-transplant, they have incorporated this little section here where they document some of the vaccines, when they were given, and then they also have additional instructions to our transplant coordinators. And as you know, with the electronic medical records, many of these are available to the patient. So if they are reading some of their own notes in the chart, it also reminds them to let us know if they get vaccines outside of our facility. So in summary, our vaccine education starts very early, and often we have conversations about vaccines at the very beginning of their transplant evaluations. We are open to giving vaccines at the clinic while people are here, but we also recognize that they may need to complete some of these at home. So we give them the information and the prescriptions they need to take to their local facilities. If anybody is hospitalized pre-transplant for additional reason, we try to use that as an extra opportunity to offer vaccination while they're hospitalized. And in the post-transplant phase, they do see infectious disease team again. They review all the recommended vaccines and when to start post-transplant. And whenever we see our patients on an annual basis, pre and post-transplant, we always ask about their vaccines. Have they had any updates? Enter them into the medical record and then remind them that they need them. I'd like to thank Jennifer for moderating, and thank you to Olivia and Rafaela and Anne for also participating and coordinating a lot of work behind the scenes.
Perfect. Thank you all for such an amazing review of the practical experience as well as some of the research focus that has been around vaccines and solid organ transplant. It's great work, guys. So now what I'd like to do, let me actually stop sharing our slideshow so you can see all of us. I want to transition now to the Q&A section and of this presentation. And there are a few here. What I'll do is I'll just kind of read them aloud and then have our panelists answer, and we can kind of go from there. And if there are any more questions as you guys kind of hear and the panelists answering them and you want to put them in the chat or in the Q&A, that's perfect. And I will kind of run through them. And any questions that we don't have a chance to get to, our panelists will all work together to answer those, and then we'll send you out individual notices about that to be able to make sure that everything is answered as a part of this webinar. So the first question we have is, can you comment on the new recommendation for the Shingrix vaccine starting at 18 and above for certain patient populations, including solid organ transplant recipients? And I'll probably give this here to Dr. Kate, our specialist in transplant ID.
Hi. Yeah, this was actually great news for us because I had been encouraging patients to seek out Shingrix vaccination even younger than age 50 if they were heading into transplant, because that was really the best opportunity to get that protection before they entered such a high risk group. And now the recommendation really reflects that. So the Advisory Committee for Immunization Practices and the CDC recommend Shingrix vaccination for people 18 to 50 who are anticipating immunosuppression. So all of your candidates fall into that group. I think insurance companies are a little bit behind the 8 ball on adapting to this new recommendation. But so far in my experience, we have been able to get vaccines and then reimbursements for patients from their insurance companies by citing that recommendation. So hopefully more and more of our patients are going into transplant having received Shingrix.
Perfect. Thank you so much. And our second question here. Good afternoon. Great talk. I do have a question with the recombinant zoster vaccine. This actually, sorry, may be a very similar question here with the recommendations and the immunocompromised, that there be new recommendations. I think we were able to address that. Perfect. And then with the new CDC recommendations for the pneumococcal vaccines, the PCV15 and PCV20, are you still recommending the PCV13 followed by the PPSV23 for transplant patients? And I'll give this to Dr. Kate as well, because I'm sure she does this a lot clinically in her practice.
Hey, yeah. So here's another new one. This time we're adapting to it instead of it adapting to us. So I think practice may vary a little bit more on pneumococcal vaccination. The Advisory Committee on Immunization Practices recommended the PCV20. Its advantages, it's more immunogenic than the existing Pneumovax or PPSV23, although it's possible that it's slightly less immunogenic than the frequently available Prevnar, the PCV13 that you may have been using up to now. In fact, that question of immunogenicity led them to hold off on giving a recommendation about which of these vaccines to use in immunocompromised patients, thinking that the slightly higher immunogenicity of PCV13 might confer some advantage over PCV20, but there are a lot of trade-offs there. Personally, I think it's going to make the most sense for the majority of our patients to use PCV20. You get the high number of serogroups, you get very good immunogenicity, and you get the advantage of doing it in a single dose. So people are more likely to get the whole job done. There are also some possible side effects from pneumococcal vaccinations, especially if they're done not quite in the right order or not quite with the right interval between them. And so sparing our patients that risk by doing a one-dose schedule, I think makes a lot of sense too. So I'm leaning toward PCV20. We just got it on formulary here, and I'm changing my practice, I guess, as we speak.
Right. And then we have a next question here that'll go to our panelists. Do you think managing the vaccination through the ID clinic adds extra time and cost to the workup process, or can it be done based on a standardized protocol?
So I can speak a little bit to that. I think certainly it may add an extra person or extra time, but when we look at the morbidity and mortality and costs of the vaccine preventable infection after transplant, I think that cost would well justify the small costs that we might have in the pre-transplant period. And if we can avoid those post-transplant vaccine preventable infections, it's not only in the patient's benefit, but also in the greater kind of healthcare cost benefit.
Perfect. Thank you so much. All right. And then our next question that we have, for patients who have been shown to have the hepatitis B surface antibody of greater than 10 prior to transplant, are you revaccinating any patients who have titers drop below 10 post-transplant? And I'll give this to Dr. Cates as well.
Sure. This one's interesting. I think that when we measure antibody titers after vaccination, we're doing something a little bit different depending on what vaccine we're asking about. And so for hepatitis B vaccines, people who lose hepatitis B surface antibody seropositivity over time actually maintain good protection against hepatitis B. And what we're often doing with this booster dose of hepatitis B vaccines is not so much adding to their protection, but just proving to ourselves that they have some memory B cells floating around that are going to churn out antibodies in the event that they need them. So I think the hepatitis B booster dose is more a test to prove you responded okay last time. And if you have that evidence of past seropositivity, you don't need that test.
Thank you. All right, our next question here, let's see. All right. Okay, so this is about the pneumococcals. I have heard some expert opinions suggesting immunosuppressed patients should receive the Prevnar 20 followed by the 23, PPSV 23. Will you stick to giving Prevnar 20 alone?
Right now, my plan is to give Prevnar 20 alone. You are going to get a few extra serogroups if you throw in the PPSV 23 afterwards, but I think that the sort of marginal benefit of adding those in is pretty small. If you have a patient who's really concerned and really a big fan of vaccines, first of all, congratulations, your patient sounds really cool. And second of all, I don't think it's unsafe to give people additional vaccines as long as you're mindful of the interval between them. But for most people, I'm just going to recommend the PCV 20.
Right, and then we have another Shingrix. So this is hot topic, Shingrix and the pneumococcal. But there are early reports of allograft rejection after Shingrix vaccination. I know more recent studies have not shown this, but I was wondering, what is the consensus on this one, and is it safe for all transplants?
This is a great question. Yeah, so Shingrix is one of the adjuvanted vaccines. And I think actually since an H1N1 adjuvanted vaccine, historically, there's been concern about immunogenicity and reactogenicity from these, very powerful vaccines leading to allograft rejection. But question asker, you are also right. It has not so far been borne out in a pretty large group now of observations of patients who've received Shingrix or now Hepatologist, another adjuvanted vaccine, either very close to transplant or at times after transplant. Right now, I think these vaccines are still not specifically recommended in the post-transplant period. And I think there are a couple of things to think about with Shingrix in particular. But for me, I'm usually not very worried about triggering allograft rejection. I am thinking about the degree of immunosuppression, and so the patient's chance of mounting a response to Shingrix. And the question I'm asking myself is, the patient's chance of mounting a response to Shingrix high enough that I would then feel comfortable taking away something like acyclovir or valacyclovir secondary prophylaxis? Because if I'm going to give them the vaccination, but I'm never going to be confident taking away their pharmacoprophylaxis, then I really haven't given them much of an advantage by adding the vaccine in there. But if they are not on pharmacoprophylaxis or don't have an indication for secondary prophylaxis, I think that they have a little bit of a benefit from getting the Shingrix even after a transplant. And so for most patients who don't have a recent history of severe rejection events, I feel really comfortable recommending Shingrix. I always talk to their organ-specific provider, so before this one, because I don't want to get in trouble.
Great collaborative practice always. So I have a question here about pneumococcal vaccines. So for those at pediatric centers, are you recommending optimization of the pneumococcal vaccines, the MCV4 and MenB, on an accelerated schedule for everyone to try to optimize this prior to transplant immune suppression, or only those with other comorbidities such as the asplenia or the complement inhibitors?
So I can speak a little bit to this. I think that it's a little bit center to center specific about how much people feel their patients have comorbidities. Definitely for patients who have comorbidities, we recommend it. If it's a standard patient, then maybe not so much.
I do not work with children, but I do in the pre-transplant evaluation try to check with my adult candidates and identify candidates who are gonna have risk factors, for example, exposure to meningococcal disease. We take care of a lot of patients with frequent return travel to visit friends and family in Africa. We take care of patients who travel to Saudi Arabia to observe the Hajj, and those patients need meningococcal vaccination because of the risks associated with those trips. And I try to get those done pre-transplant so that patients have at least a 5-year period where they might have the optimal protection from pre-transplant vaccination.
All right, and I think we maybe have like time for 1 or 2 more questions, and I'm gonna try to give these to the panelists as I'm scrolling here through. So someone is asking if it is feasible to do all of the vaccinations and all of the practical experience for giving vaccines without the use of ID.
So I think it really depends on the knowledge base of all the members on your team and their interests and how much extra learning they've done. But I would say in my experience, it is always beneficial to have infectious diseases as part of the team. There's so much in the pre-transplant and the post-transplant period where infectious disease can really supplement our organ-specific knowledge. So I would really recommend that people consider getting ID as involved as possible.
I've
Right,
tried several times to invent like a checklist that could be used, to replace me. Probably a fool's endeavor in many ways, but so far it just hasn't been possible because these recommendations do get tailored to some pretty specific details about the patients, and I have not been able to anticipate all those details well enough to provide a resource that could do the job.
All right, and then this last one is the last one of the day here, but Dr. Feldman, would you tell us more about the app and if it is available for other centers?
Yeah, absolutely. So the app is really right now in a research stage. Like we talked about in the beginning of the talk, I'm funded by the Agency for Healthcare Research and Quality, and part of my K award was developing this app. It currently is being trialed amongst pediatric heart, liver, and kidney transplants at 3 large centers across the country. We hope to have data within the next 2 years, and then our goal is really to make it accessible and available to all transplant patients across the country. So right now it's research only, but stay tuned. We would love to really make it a tool that all patients and all teams can make use of.
All right, well, thank you guys. We're at the end of our discussion today, but I did want to thank all of you as presenters here for giving us such a wealth of information and practical experience to help us with our vaccinations and our own transplant groups. And I do want to also thank AST for the ability to use this platform to be able to do a very timely review of vaccinations, which we always have questions about. So thank you, everyone. And I'll turn it over to Anne here for a last minute close-up.
AST would like to thank our panelists and attendees for today's session. Please remember to complete the evaluation survey. Enjoy the rest of your day.
Thank you.